Thanks for taking the time to look at this PowerPoint presentation. I just wanted to put together as brief as possible but thorough account of nuclear medicine, its production and its waste. At the moment there's a lot of debate around as to the role of nuclear medicine, in particular the role of radionuclide production for the provision of nuclear medicine services throughout Australia and how its waste is managed. And so we'll talk to that in a few minutes. I'm aware that there's presentations available. There's a webinar that the Department of Industry, Innovation and Science ran last year. There'll be another one coming out shortly. There's presentations that I've done. There's presentations that other people have done as well. So I just wanted to try to put everything in a bit of a nutshell because clarity is really important. And so I come at it from a perspective of science. I'm not a nuclear medicine physician. Nuclear medicine physicians are expert in reporting the films or the studies and providing medical diagnosis and opinion. I come from the science perspective, and I've actually had over 30 years in the nuclear medicine industry and have a bit to add to the discussion and debate. What I will say about my presentation is that everything that I say and everything that I present, I can back up with actual evidence. And that's really important because it's easy for me to say something, it's easy for someone else to say something, and it's easy to sort of handpick a little bit of evidence here and there. It doesn't make it right. You've got to remember that the information age propagated by the internet is that there's a lot of graffiti out there. Essentially, there's just because something is written on the internet doesn't make it true. And so if anyone has any questions or concerns, I'm more than happy to provide the evidence to support everything I do or say. So I just want to introduce a couple of people in the discussion. And I don't want this to be a negative discussion. It's not here to out anyone in particular, but it is important to put a name and face to the characters that are in this play. So it's really important, and I have respect for these people, and it's really important that I flag that the reason that we're talking directly to these people is because these people are very, very passionate about what they do. Okay, so they're smart people, they're passionate, they believe in what they're doing and saying. Even if I don't agree with what they're saying, I have to have an enormous amount of respect for them because they truly believe and they have passion and they have drive to pursue what they think is the right thing. And that's important to put into context, because if you don't put that into context, then you miss the fact that if the rest of us don't have that same degree of passion, if there's a degree of ambivalence from either the community or from the professions, and so we don't actually stand up and provide an alternative view on how things should be done or the need for certain things, well then the passion of these four people and their colleagues just roll over the top. And so it's really important. You can't just sit by and be out enthused by some really smart and passionate people. And so for the Medical Association Prevention of War in Australia, Margaret Beavis is a general practitioner, and Peter Karamoskis is a radiologist with qualifications in nuclear medicine. So they come with a high degree of pedigree. They actually use their medical background and the trust that comes with that. I mean, the Australian community really puts a lot of trust in the medical community, and so they come with credentials that that actually back up, that give some substance to their claims. What you need to keep in mind is that being a general practitioner doesn't make you expert in anything to do with radiation, let alone nuclear medicine and its science. And being a radiologist and even a nuclear medicine reporting doctor doesn't necessarily mean that you actually have a full understanding of the science associated with its production. So you're an end user rather than at the front end. So really smart people and have really strong views, very passionate and work very hard. Jim Green with Friends of the Earth is that he's actually a very active anti-nuclear lobbyist, and he has some fairly strong views that we'll touch on shortly. And of course, Dave Sweeney, who I've had a lot to do with over the years, in the recent years, with the development of the National Radioactive Waste Repository project that is currently being discussed in South Australia. Dave and I and others were on independent advisory panel that helped the government to formulate a mechanism and plan for how how sites were nominated and then assessed for suitability. So Dave's a really good guy to talk to. I've had a number of great discussions with him about some of the content of this presentation. He's very smart in the way that he actually portrays information, and he actually understands some of the science, even if because he goes out seeking that new information. I do want to say that my concern with the Medical Association Prevention of War and Friends of the Earth and Australian Conservation Foundation is when they make actual claims that we're going to address in this presentation, I think it actually undermines their own credibility, because Medical Association Prevention of War, you actually want to attract people who have a history or have a professional qualification in health and medicine, who are drawn to the MAPW to fight against war and the horrible ramifications of war. And in particular, no one would dispute wanting to stand up and say we need nuclear disarmament so we don't have a nuclear war. But to actually attack nuclear medicine sort of undermines the value and the attractiveness. I would love to be able to support MAPW and Australian Conservation Foundation and Friends of the Earth, because their philosophy towards the name, the title of their actual business organisation, it actually makes sense. But the way it actually manifests in reality is that they're undermining the very integrity of their own organisation and the health and well-being of every Australian. And so I can't support them on that simple basis. That their big picture stuff is really important, but they're destroying that with their little picture stuff. And so, the problem with the discussion amongst these three groups is that, and the reason they're attacking nuclear medicine and the Opal reactor at Ansto is because they have this very firm belief that all nuclear ends in nuclear weapons. So they believe that the research reactor at Lucas Heights in Sydney is the first step to nuclear power and nuclear weapons. And they're completely unrelated. And the reactor at Lucas Heights can't be turned into a nuclear weapon. There is no evidence to connect medical isotope production for the health and well-being of communities with nuclear war, nuclear weapons, or even dirty bombs. So there's absolutely no connection. It's completely fallacious, and it actually really hurts not only our industry and our community, but it actually hurts their individual organisations as well. But as I say, very passionate players, and you have to respect that. And if you don't respect that, well, then their enthusiasm will override, common sense in terms of how nuclear medicine plays out over the next 20 or 30 years. So I guess that the difficulty is that we're being sold a beautiful Big Mac, as you can see there on the right. I have no commercial interest in McDonald's, so I'll just declare that right up front. We're getting sold this perfect Big Mac, but you know that when you actually buy that Big Mac, when you actually unwrap it, it looks a little bit more like on the one on the left. And so we have to be really mindful that what we're told in these, unicorn and rainbow scenarios that we get at the moment about what the perfect world is that, these groups are not there to pick up the pieces at the end of it. Is that if nuclear medicine falls over, if Opal reactor closes down, and because these people have actually pushed for that, and nuclear medicine services in Australia are not as good as what they would, or too expensive for the average person, it's not going to affect them. Is that, you don't think that, the high income earners are going to not be able to pay that little bit extra. It's going to hurt the average Australian, the lower socioeconomic groups that represents the bulk of Australians. And in the debate around the National Radioactive Waste Repository, you don't think that these people who are actually saying no, you can't actually have this waste repository in rural South Australia, you don't think they're actually going to come back and actually help to financially support those small communities. Once this debate's over, they're gone. They won't be back. They're not going to be back to support that community. And so if that community struggles to make ends meet moving forward, to have a future, not turn into a ghost town, then these people are not going to be there. They'll blow in, have their argument, and then blow out again, and then blame the government for not actually having a waste facility. So it's kind of a no-win situation. at the moment, the argument is, no, you can't have it in rural Australia. It makes no sense. We're going to oppose it. But then the criticism is that the Australian government hasn't actually got a waste facility. So it's a little bit double-ended. So what are the claims? The claims are kind of interesting because these are the four main claims that I want to address in this presentation. Of course, there's a whole bunch of other discussion points around these, but the first one that comes from the MAPW and ACF is that radionuclides can be produced in a cyclotron, so we don't need the reactor. The second argument is we can import all of our nuclear medicine instead of produce them ourselves, and that again comes from the MAPW and ACF. And because of item 1 and 2 above, that means that we don't actually need the radioactive waste repository. Okay, so they're arguing that because of 1 and 2, we don't actually even need this waste facility, which actually contradicts their very arguments about, or complaints that the government hasn't actually done anything to address the waste storage and disposal anyway. So makes little sense, but that's an argument that comes out. And an even more concerning argument comes from Jim Green of the Friends of the Earth, who has actually made claims that nuclear medicine actually kills more people than it saves. And so I want to address all four of these claims. So the first discussion point is cyclotron production. So cyclotron production has been dealt with many times before. I've had this discussion amongst communities. There's been plenty said at the webinar that the department produced, and the whole foundation of this is that MAPW and ACF have sort of got this idea that the Canadian model is the model to follow. So it works for the Canadians, so it should work for Australia. And what they're neglecting is that there's just been a couple of published papers from the Canadian team that have said that we can actually produce technetium-99m, which is the radiopharmaceutical responsible for 85% of nuclear medicine procedures in Australia and the world. So they can actually produce this radionuclide in a cyclotron. And this follows the fact that they had some major regulatory and financial issues with their reactors that ended up getting mothballed. And so without a reactor in their country to produce these radionuclides, they turned to what they thought was the next best option, and that's the cyclotron. And so that's nothing new, is that technetium-99m was actually discovered in a cyclotron. So they're not telling us anything we don't already know. We know we can produce it in a cyclotron. We just can't produce it in large enough volumes to actually meet the commercial needs of our communities, let alone the global community. But we keep coming back to this Canadian model. The Canadians did it and are doing it, so everyone else can. And there's big problems with this that I'll discuss over the next couple of slides. So yes, cyclotrons can produce technetium-99m directly. That is not new. That comes from 1970. But we also produce other radionuclides in cyclotrons, and so we have a number of cyclotrons in Australia that range in size from 8 MeV. So MeV is the rating is the maximum energy that it accelerates particles to. So obviously for some things you need to accelerate to higher energies to produce, and so we can get away with 8 MeV for fluorine-18, which is a main PET radionuclide. But there's other products like gallium-67 and thallium-201 and iodine-123 that need much higher energies. We're talking 20 MeV or more, and we have no cyclotron in Australia that can produce those radionuclides. So we do have to ship those things in, but they have long half-lives, and that's important. They have long enough half-lives to ship them in, but they come at a very high cost, and so we don't do it very often. We prefer to rely on our local supply. So what do you need to produce technetium? So you need about 15 to 16 MeV to produce technetium directly in a cyclotron. And we have 3 of those cyclotrons in Australia. All of those cyclotrons have other things they need to be producing. You have to have special targetry. Essentially is that the volumes are fairly low. There was a very interesting, if you go back to the webinars that you could see on my YouTube channel, there's a very interesting point in that webinar where Peter Karamoskis and Margaret Beavis, and I have to point out that Peter was representing the Australian Conservation Foundation in that webinar, not the MAPW, is that they got to a point where they didn't realize that a 9 MeV cyclotron can't just have some additional hardware tacked onto the side to to turn it into a 15 or 16 MeV cyclotron to produce technetium. And the comment was, and you can go back to that that webinar, the comment was, well, our sources say that you can. And the collective medical physicists and other experts around the table said, well, that's absolutely not true. And so it really highlights the fact that, you know, we're being given policy direction from the MAPW and ACF from people who not only don't understand it themselves, but they're actually getting their sources of information from third parties who also don't understand the science of it. So that to me is enormously problematic. So the Canadians have trialled it. It's not their first choice. And there's a number of teams around the world that have actually also trialled it, and that includes me. So I've actually done some research as part of a team overseas in this production. So I have some insight. You can see there that one of my papers, or one of the poster presentations that I was part of the team, won second prize at a big radioisotope conference. And of course, you know, there's a team of people across many countries involved in this project, and then similar production using different size cyclotrons or energies of cyclotrons. So I have insight into how it all works and the theory of it. And so one of the issues is that you actually need solid targetry, which you don't always have access to, and the target is molybdenum 100, which occurs naturally amongst things like copper tailings, and it has to be fairly highly enriched. And so there's only one source of molybdenum 100 suitable for bombardment in a cyclotron anywhere in the world, and that comes out of Russia. So remember that the MAPW and ACF are against enrichment. So here we're actually got in a process that requires enrichment to produce it. It gets bombarded through the accelerator up to about 15 MeV, and as a result, you end up producing technetium 99M. You can produce more with higher MeV, which is what the Canadians are doing. They're using like 30 MeV or so. But the problem with that is you also end up with more chemical contaminants. So with a 6-hour bombardment with 30 MeV, the Canadians have shown that they can generate 350 gigabecquerels. So that's just a unit of measure. Some of you will understand, some of you won't. But let's just say 350 gigabecquerels is not a lot. So I've already mentioned that we already knew all this from 1970. And the problem is that we don't have any large cyclotrons in Australia. We've only got the 316 MeV, so it would need a complete restructure, both from an infrastructure, economic, and geographic perspective in Australia to make this work. And it hasn't worked geographically in the US either. Is that 350 gigabecs is enough to supply like 2 hospitals in Vancouver. It doesn't actually filter out to any other parts of Canada. There's not enough of it. So after that 6-hour bombardment, which means that it's not doing anything else during that time, you could, if that's what you got, you could probably supply 4 departments. If they're busy departments like the Sydney Teaching Hospitals, maybe 2, maybe 3. But the problem is it has to undergo this process of quality assurance. And that process of quality assurance when you're dealing with a 6-hour half-life. Now remember, in the reactor, we're producing the parent of this. We're producing molybdenum 99, which decays to technetium 99M. So we're dealing with something with a 67-hour half-life. So we've got time to actually process it. Here we're dealing with a 6-hour half-life. So it undergoes approximately 3 or 4 hours of purification, which means that you end up with 200 gigabecs left. So you're almost half has already gone just to actually undergo quality assurance on this product. The problem with it is that the literature that's been reported is that even after those 3 or 4 hours of quality assurance and purification, it ends up at a point where the purity isn't adequate to pass TGA commercial standards in Australia. So it isn't as good, it isn't as pure, and it hasn't got the same quality as the technetium 99M we currently use in Australia. And despite that, it still has increased costs. So it's more expensive to get less and get less quality. And so to purify that to the point where TGA would approve it, then you might need another 4, 5, or 6 hours. So you end up with 100 gigabecs. Well, that's what we would send to a major teaching hospital. So you've got one department being supplied. See, other assumptions about the reactor redundancies are that it ignores that there's a whole bunch of radionuclides that aren't technetium-99m that are produced in the reactor. Okay, so we have lutetium-177 and we have samarium-153. Some of these radionuclides are not just for diagnosis, but they're for therapy. They're actually curing disease, or they're actually providing palliative care, or they're actually prolonging life. So it's not just about this one diagnostic radionuclide. There's a whole raft of things that are produced in the reactor, and they're ignored in this cyclotron model. It also ignores the knock-on effects that we have for New Zealand and Southeast Asia. You know, Australia has a global responsibility, and certainly one in our region. We provide leadership in health and medicine and science and other things. And we're ignoring that. We're going, okay, let's turn our back on those people that have relied on the ANSTO service for so long. And we turn to those countries for support from time to time as well. So we can't sit there and go, oh, okay, well, let's just look after Australia. This seems to be the attitude of the MAPW and ACF. Let's just worry about Australia and everyone else can sort of, sort themselves out. Well, that doesn't work, because what happens when Australia goes to those countries and says, look, we need your help, right? You've got to be a global citizen. It also ignores the fact that we don't have the expertise to man the solution at the moment. We have a centralised expertise in Sydney at ANSTO, and to actually decentralise that all over Australia would be, first of all, there wouldn't be enough manpower in terms of the expertise needed to run these cyclotrons, but also people wouldn't want to be decentralised in that manner. It ignores the enormous increase in the daily road freight, so you're actually going to have more radioactive material on the roads more often, going further and more frequently. It ignores the fact that cyclotrons generate their own waste, and in actual fact, one of the biggest waste products sitting at ANSTO at the moment waiting for a national radioactive waste repository is the old cyclotron. So the old cyclotron that was big enough to produce technetium-99m is sitting there in lead-lined bins waiting to be disposed of, because it produces its own waste, and it's radioactive waste. It ignores that cyclotrons do not provide an on-call solution, so you've either got to be running these things 24 hours a day, which just doesn't work in many sites. The ANSTO generators that we actually get, the ANSTO service, means that you've actually got a 24-hour supply of the product. It ignores the quality assurance issues that the ANSTO generators overcome. The unit itself provides its own quality assurance mechanism to give highly pure technetium-99m that gives good quality scans. It ignores that there's no alternative revenue stream to offset production costs. Right, so at the reactor we have doping of silicon, we have the research in the neutron beams, we have other things that go on there, that the income stream offsets the cost of production. So it means that the cost of the medicines in a cyclotron are not going to have that offset and will significantly increase. It also needs to think about the tax implications. When we have a national facility, it's paid for with national taxes. But if all of a sudden things become local, that each local community has its own cyclotron, then all of a sudden that becomes a local burden. You don't actually have that differentiation, or that diffusion of costs of a national solution. You've actually come down to local community solutions. And as a result, lower socioeconomic groups or communities that have a lower socioeconomic status in this country, rural and regional communities, they're actually going to not be able to afford these facilities. So we'll end up with a 2, 3 or even 4-tiered healthcare system. And the Australian geography and population dispersion just simply doesn't allow the network to be built. And the Canadian network solution, it was never a solution. It's never been a solution. They had a proposal about how it might work. It's never been able to work. But even the proposed solution that they had for Canada, where their population distribution, is that wouldn't work in Australia, and it certainly didn't work in Canada either. And it overlooks community redundancy of downtime. So if you've got a community that actually has one cyclotron that services a large area, so in my hometown in Wagga Wagga, we would service a community of 250,000 people in a large area. Well, we can't afford 2 cyclotrons. So when the one cyclotron is down for service or it breaks down, then it means that our community doesn't get service. But we could do it. It could be done. And so this is how we could do it. I was asked how we would actually manage it. If you're looking at 20 plus MEV cyclotrons, there's currently none in Australia. You'd be looking at about $30 to $50 million startup costs for each of them. You'd need 5 in Sydney, 4 in Melbourne, 3 in Brisbane, Adelaide and Perth, 1 each in Hobart and Canberra. And so you'd have a total startup costs of nearly $1 billion. That doesn't include your manpower. It doesn't include the production costs. So that's like 2.5 ANSTO reactors just there. Then you'd need a bunch of smaller 16 MeV cyclotrons to produce the local supply. You may be able to double that up with PET supply as well, but you'd be looking at about a $15 million startup costs. That doesn't include service and ongoing costs and maintenance and stuff. That's just the actual capital to start it off. And you would need a whole bunch of them in Queensland and New South Wales, Victoria and Tasmania, WA, Darwin. And so you would end up with, $15 million startup costs multiplied by 30 or 40 sites minimum that you would need to distribute those to. So it'd be enormously expensive. So what are the questions? What's the cost of training and relocating appropriately qualified staff to run the chemistry, the IT, the physics? What's the cost and the risk of road transport daily? What's the backup plan for when the local cyclotrons are on maintenance or breakdown? If the current rural and regional PET departments who rely on cyclotron production from somewhere else can't get reliable supply, how's it supposed to work for technetium when it's 85% of nuclear medicine studies? It's just going to magnify that problem. But it is important because we keep getting the Canadian model thrown back at us to actually reflect on the Canadian model. And Canada did not opt for cyclotron production. They did not opt out of reactor production. They had a cyclotron was a plan B when their Maple reactors, after being invested with $680 million, they had a whole bunch of regulatory and engineering issues that we were very fortunate in Australia the government planned very differently to Canada. And so as a result of those failures, they end up being mothballed. So they turned to cyclotrons optimistically, hoping that it would actually fit and provide us at least a local solution. And it hasn't worked. Okay, so it hasn't worked. They can actually supply a couple of local hospitals, but it's not providing a national solution. And I can tell you right now that the Canadian cyclotron experience has been such a failure that now Canada has turned back not to medical reactors, but nuclear power reactors to produce molybdenum-99. So they have now gone, okay, well, let's go back to those nuclear power reactors and see if we can actually, and there's one in particular that is designed in a way that allows them to produce molybdenum for medical use. So the Canadians have flipped back. It's been such a failure. This is the model that the MAPW and ACF want in Australia, and no doubt is being supported at the moment as a reason for not having ANSTO or the waste. But the Canadians have flipped. They've gone, you know what, it's a failure. We need to go back and find another solution. And they've gone to nuclear power reactors to produce molybdenum-99. And the US has invested heavily in reactor production for nuclear medicines. So here's the thing, is that you can't stick a traffic cone on a donkey and try to sell it as a unicorn. And that's what's being happened. This is what the ACF and the MAPW is saying. They're giving us this, magical thinking associated with the cyclotrons on the basis of some truth. And the truth is you can produce technetium-99m in a cyclotron. Can you do it in a commercially viable way? No, you can't. Not to provide a national solution. So they're sticking a traffic cone on a donkey and saying, okay, here's a unicorn, here's our magical solution. And you just can't do it. We can't be fed that kind of rubbish. Okay, so we need a little bit of respect for our intellect as Australians and trust that we can actually make those sorts of judgments. So part 2 is actually gets kind of interesting because this is more of a we've actually got a local insight into this more recently. So part 2 of it is that when I argue that the cyclotron doesn't work, or it's not going to work for a national solution, but it might actually work for a small local community, then the solution is, well, in those small communities that can have a cyclotron, great, but the rest of them we can just import. We can just import our radionuclides that we need. And we do import some of our radionuclides already that we can't produce in this country. And so we need to keep in mind that reactors do not produce technetium-99m directly. It's got a short half-life. They produce the parent molybdenum-99, which has a long half-life, and that allows us to load it into a generator, or a mechanical device that gives us supply up to 2 times, sometimes more if we need to, but 2 times a day, we can actually get some technetium off that to use for our patients. So it means that we only have to have it transported once a week. We've got a daily supply. We've got a supply during the night for emergencies. We're going to supply over the weekend for emergencies without additional road transport. The structure itself creates a degree of radiochemical purity because of how it works. And, you know, we can actually recycle. So it's not uncommon for a big site that has a big generator to actually send their big generator to, at the end of the week when it becomes a small generator, to a smaller site. So that's actually, you know, sustainability and it's environmentally friendly. And so this is, excuse the typo up the top, is that this is the model that the MAPW and ACF want to push us to. What they want to do is actually have a system where we import stuff from overseas. So the reactor produces the radionuclide and then it is shipped. So we can't talk about Canada now because Canada's closed down. But in Europe, it might be shipped across an international border to a molybdenum extraction plant. And that shipping takes time, our radioactive decay, increase our costs. And then it undergoes extraction. And then it's shipped from there to a third site where it's actually produced into the generators. And that also involves increased time, increased cost, decreased activity, so we end up with less product. Then we have your generator production. It needs to be shipped to the hospitals and clinical sites. And for this to occur in Australia, it requires 3-4 days of international travel. So we end up with decay during that time as well. This is the Australian model, and this is why the Australian model is the envy of the world. Okay, is that the reactor production, the molybdenum extraction, and the generator production all occur in buildings literally on top of each other at one site. You do not have decay and increased costs associated with transport. It's all done at one site, one centre of excellence. And then it is shipped out to departments in Australia and in our regions, so New Zealand and Southeast Asia. So it provides not only a really good cost-effective model, but it also means that it's more sustainable use of resources because we don't have to produce as much radioactivity to start with because we have less decay through the transport process because the extraction plant and the generator production facility is all on the same site. On top of that, you actually have commercial applications. You know, I've mentioned before silicon doping, which decrease the costs. There's a whole bunch of research that's associated with it that displaces some of the waste and improves the outcomes. We already talked about the single site, but also the Australian model is the only medical reactor in the world that uses both low enriched fuel and low enriched targets. So that decreases cost, decreases waste, and it makes it more environmentally sustainable. And so isn't that what the MAPW and the ACF want from us, to sit there and actually be using this low enriched product? So to close the ANSTO reactor or to start importing instead, what it would essentially do would be pushing us back to using high enriched uranium. And I'm pretty sure that's contrary to what the ACF has been suggesting. So we have a really good lens for this because over the last 7 weeks, you know, today is the 2nd of August, so in 2018, for those that are listening to it at a point later on, is that in the 7 weeks preceding today, when I recorded this, is that we've actually had an issue at the reactor. It's not associated with the reactor itself, it's actually associated with the hot cells where the molybdenum is extracted. There's a breakdown in there that has actually seen us have to import for 7 weeks. And so we've actually had a really good opportunity to see what the model is that the ACF and MAPW has been pushing. And I can tell you it's ugly. So the ugly truth is that molybdenum decays with a half-life of 67 hours. And I've already mentioned that. So the processing and transport time alone means that more than double of the activity that we need has to be produced. Right? So that means that the solution that the MAPW and ACF want to push, even under the most ideal circumstances, I can tell you it's not ideal, but even under ideal circumstances, will reduce the nuclear waste footprint in Australia, but it will substantially and disproportionately increase the global waste footprint. right? So if the MAPW and ACF say, look, we don't care what happens overseas, we're about waste and whether it's enriched and all those other things, is that as long as Australia doesn't have waste, then that's okay. So that's what we're essentially saying, that that solution would reduce the nuclear waste footprint in Australia, for sure. But it wouldn't just send that waste footprint overseas. It would substantially and disproportionately increase the waste footprint because we have to produce so much more, and it's more than double. It's more than double that we have to produce. So we'd end up with significantly higher global waste footprint compared to what we would lose here in Australia. And it's the only, as I said, we're the only provider of low enriched uranium fuel and targets. And so if we followed the MAPW and ACF solution of importing, what you would actually do is drive up the use of enriched uranium. It would actually propagate more enriched uranium use globally. But that's okay because it's not in Australia, so they don't care. So we need to be thinking about being global citizens and looking at that global sustainability, not just looking at it in a silo of what would happen in Australia. So molybdenum technetium generators arrive into Australia and have been in transit for more than 3 days. So by the time we get these things arriving in our departments, there's substantially higher impurities in that first solution, and that can undermine quality of the product and the quality of the diagnostic outcome for the patient. And it's the upshot of that means that many departments will have to forego operation on a Monday each week, or decrease the diagnostic accuracy, or risk decreasing it. The other thing is there's a number of transport delays. We see it's unreliable access. Pilots have the option of actually bumping things off their cargo. You can't, international transport regulations prohibit radiation from being transported with animals or with deceased bodies. There's a whole bunch of reasons that it might be offloaded, and as a result it gets to Australia late, which undermines our service, it decreases the activity, it increases the costs. And in particular in rural and regional sites, they'll suffer enormously from having these delays to life-saving and life-changing treatments and diagnoses. And so it creates this multi-tiered healthcare system, and we've seen that over the last 7 weeks. We've had a situation where we have the haves and the have-nots. And it's inequitable service, and it's unsatisfactory, and it's costing people lives and life expectancy and quality of life. And if we had that for more than 7 weeks, if we had that in a situation where we had it for permanently moving forward, as the MAPW and ACF would want, then we would actually see a significant change in the health and well-being of not only all Australians, but specifically in some communities it'd be worse than others. So clearly importation is both a disadvantage for Australians, but it's also counter to the position that MAPW and ACF have on waste generation and enrichment. So it makes no sense. And there's also other products. So not all reactor produced nuclides are from fission. We actually have other products that are produced in the high neutron flux associated with P32, strontium-89, that may be produced for diagnosis or therapy. And so I guess the upshot here is that don't try to sell us gold that they've never seen. They've never seen the end of the rainbow, and none of us have. So they're trying to sell us what's at the end of the rainbow as gold, and it's not always gold. So and there's no end to the rainbow. So let's not get dragged into this false sense that there's gold at the end of that international import rainbow, because it's more likely to be what's in this diagram. So the next part is the waste, obviously, so the argument is that based on 1 and 2 that we don't actually need to manage the waste because the MAPW and ACF would have ANSTO closed down. So I've argued that number one, that would be disastrous for Australia and the health of Australians. So let's just accept that part 1 and part 2 they just can't happen in the Australian healthcare system. So we have to manage the waste, and we need to get the understanding of the waste correct. And so one of the things that's really important is that to understand the actual sheer volume of this waste. So let's assume that we're going to live for 80 years, and the average life expectancy of an Australian is 83 years old. So your share, So if we just said, look, what's your share of the ongoing waste? Right now, we've got to remember that the average Australian will have 2 or 3 nuclear medicine procedures during their lifetime. Some people will have 10 or 15 or 20, other people will have none. But on average, it's 2 to 3 per Australian. So if we said it's everyone's responsibility to store the waste, what would your share be over the 80 years of your lifetime? Right, so all the stuff that would be produced by ANSTO in the future, and your share would be 0.13 millimeters cubed. Right, so if you actually pick up your pen and you look at the little ball in the end of your ballpoint pen, it's less than that. It's less than that. That's your share. Okay, that's the level of waste that we're talking about. So without the reactor, the number of Aussies having their lives saved or changed by nuclear medicine will drop significantly. And if we have a drop in the number of lives saved or changed by nuclear medicine, you will actually see a decrease in the average life expectancy as well. So the MAPW and ACF claim that the bulk of nuclear medicine waste goes to landfill. And the bulk of the stuff that we actually have in our nuclear medicine departments is true. That is true. But we've got to produce the medicines to start with. Okay, so when I actually inject a patient with a dose, and I've got syringes, and I've got needles, and I've got gloves, they're stored locally and then disposed of as normal waste. Okay, because of the radioactive decay. And so that's not the kind of waste that we're talking about. We're talking about the actual waste associated with producing the medicines in the first place. Okay, so if we follow the MAPW and ACF's argument, it's akin to saying that the only waste associated with a meal is what you leave on your plate at the end of the meal. And we know that the majority of the waste is going to be associated with preparing the meal in the kitchen. And so if we ignore that waste and just focus on the little morsel that's left on the side of the plate, then we're not really giving a true account of the actual waste. So it's that waste in the production process. 75% of the low-level waste and 98% of the intermediate-level waste currently produced are directly related to the production of nuclear medicines in Australia. So without the production, there's no nuclear medicine. It's not different to the waste from the food cycle, as I've just described, but also all those other cycles. So every resource cycle, whether you're actually producing, let's come back to the ACF's, enthusiasm for solar panels. And solar panels are great, and you should have them on your house and all those other things. But to produce solar panels, you actually have to increase mining, rare earth metal mining. You have toxic waste associated with the production. You have toxic waste associated with the end of life. But they don't actually count that in the actual waste cycle. Okay, but you have to look at the entire scheme. So the end product used by the consumer is not the critical waste point. It's the actual production process itself. So unfortunately, over the last few years, I've really got this sense that the Australian Conservation Foundation and even the MAPW have a target on ANSTO and have a target on the healthcare system in Australia. They don't understand the value of nuclear medicine and the value of production to keep Australians healthy, maintaining their well-being. So for me, it really is quite frightening to think that we have such a large organisation like the Australian Conservation Foundation really trying to steal away the health and well-being of Australians. So it brings us to part 4, which was the comment made by Jim Green that nuclear medicine kills more people than it saves, and that's just frightening, frightening to think. So each year there's about 700,000 nuclear medicine procedures done annually in Australia. So the average for every Australian, you'd receive a nuclear medicine dose every 36 years. Okay. Now some of us will receive more and others will receive none. We already know that. But this data is based on their Medicare benefits schedule only. Right. So these are only patients that are actually done on Medicare. They don't count the patients that pay privately, or the patients that are actually included in the state hospital budget. Or state health budget rather than back onto the Medicare benefit schedule. So it's actually likely to be higher. Well, not likely, it will be higher. I'm just not sure how much higher because that data is not readily available. So on average, the average Aussie will get 2.5 scans in their lifetime. So nuclear medicine changes lives. It don't just save lives, it changes lives. And it's not a matter of measuring how many lives are saved. That's a lot. We do therapy, we do diagnosis. It also changes lives. Earlier diagnosis means that you actually have better life expectancy after diagnosis and after treatment. It means improved quality of life. If you have improved quality of life, it has enormous implications for society. Not only is your mental health and well-being better, but it means that you're actually more productive in society because you go back to work. When you go back to work, it means that you're economically productive, you're in a better financial position yourself, you contribute back to the economy of the society. And so it's actually better for all of us to have those changes in lives. And NucleMed does what other tests and modalities can't do. We're not out there trying to redo or reinvent other tests. We're not sitting there saying, okay, well, we don't want this CT scan anymore, we're going to try to compete with it. We are doing things that other modalities can't do. We're diagnosing diseases at a time when other modalities can't do it. So some of our tests diagnose dementia, for example, 8 years before symptoms develop, 10 years before changes in MRI or CT. We're seeing, hemodynamically significant disease that can't be assessed with other imaging modalities. It's heart disease, it's neurological disease, it's cancer, it's lung disease, it's GIT, GU. It's life-saving, it's life-changing. And it's really important. And that's just diagnosis. We also have the therapeutic doses that we do, which is an increasing component of nuclear medicine. So the total lives lost in Australia that are attributed to diagnostic nuclear medicine radiation dose is 0. The total lives lost in Australia that are attributed to therapeutic nuclear medicine radiation dose is 0. The total lives lost in Australia due to radiation dose performing nuclear medicine, so that's for staff, so people like me performing the nuclear medicine scan, is 0. So to suggest otherwise fails to understand radiation biology. Even if we wanted to apply the debunked or rejected linear no threshold model, that wouldn't change. Where Jim Green is getting his information, I have no idea. It is possible. It is possible that catastrophe could occur. I know that the United States is a gamma camera collapsed over on a patient due to an engineering failure that killed the patient. That had nothing to do with radiation. It was all to do with an engineering fail and actually, poor quality management. But we use what's called the tracer principle, and clearly it's something that's not understood outside of nuclear medicine. So the tracer principle means that we're using radionuclides in such a small amount that they have no physiological effect on the patient. So for example, when we use thallium-201 or thallium thallus chloride, thallium's a poison, as many things are. Water's a poison if you have too much of it. So thallium might be used as a poison in many old movies, and even in the recent James Bond movie, I think it was Spectre, they used thallium as a poison. But we use it in such trace quantities that it actually has no physiological effect on the patient. And our doses are very similar. So our actual radiation risks, the deaths associated with nuclear medicine in patients and in staff associated with radiation is 0. How that exceeds the number of patients whose lives saved, I'm really not sure of Jim's maths. So let's look at the numbers. The average Aussie, 2.5 procedures in their lifetime. Let's pick the ones that are the big ones. Okay, so the big doses, I mean. So 3 millisieverts for a bone scan, 4 millisieverts for a cardiac scan. So let's assume they're having 3 tests done, and a renal scan with 2 millisieverts. So that's 9 millisieverts the average Australian's going to get over their 83 years. So over 83 years, the average Aussie is going to have those 3 big tests with a total of 9 millisieverts distributed over 83 years. That's the equivalent of eating 3 bananas a day. It's the equivalent of sleeping next to someone for 60 years. So if you were married and you were sleeping next to someone for 60 years, the additional radiation dose that you would get by having a person, because our bodies are radioactive, sleeping beside us would be 9 millisieverts. Okay, so put it into context. The background in Australia is about 1.5 to 1.7 millisieverts, depending on where you live. And so that's 6 years equivalent background over 83 years. So over 83 years, you're getting the equivalent dose of about 6 years of background spread over 83 years. We're really talking nothing. Staff working in nuclear medicine get on average about 1 millisievert per year. but it can be as much as 50 millisieverts. Not that anyone gets that, but in terms of the guidelines, is that we're allowed to get 50 millisieverts in any 1 year, or 20 millisieverts averaged over 5 years, so 100 millisieverts over 5 years. But our average doses are less than 1 millisievert. Pregnant staff members can actually have 5 millisieverts during the term of their pregnancy, right? And Jim Green is telling us that patients that get 9 millisieverts over their lifetime of 83 years have got this huge death rate compared to the number of lives saved. It's crazy. A whole body CT scan, which no one argues with, is 30 millisieverts. So 3 times higher, or more than 3 times higher in one go, that the average Australian will get over 83 years. 80 millisieverts is the 6-month dose limit for the International Space Station. So we send these astronauts up there to spend 6 months living in the International Space Station, and they get 80 millisieverts in 6 months. And here we're looking back at the average Australian getting 9 millisieverts over a period of 83 years in their life. And of course, 1,000 millisieverts in one single dose. So at one time, you need to remember that, doses, it'll depend on whether you actually get one big dose or a whole bunch of small doses over a long period of time. Obviously, a big dose in one hit is more likely to have an effect than small doses over a long period of time. But 1,000 millisieverts all delivered in one dose is what's required to kill about 50% of the population in 30 days. So we are so these are the doses that are fatal, right? These are the doses that actually don't change outcomes for patients. So I'm not sure where Jim gets his numbers from, but just rest assured that when you're actually looking at these numbers, 1,000 millisieverts in one dose is something that you don't even get in radiation therapy patients. Okay, so our diagnostic and even our therapeutic doses are much, much smaller, and we're talking, 9 millisieverts over 83 years for the average Australian, which is 3 bananas a day, sleeping next to someone for 60 years of marriage, or just 6 years of natural background radiation in Australia. Now, this is a very complex, complex in terms of small text, so we're not going to get too bogged down. But what you actually get the impression of is that things start small over there in the blues. So sleeping next to someone is the small one, eating a banana or eating one banana, through to having an arm x-ray. Very small doses. The larger blue boxes at the bottom are airline flights from New York to LA, which would be the equivalent to Sydney to Perth. Then we start to get into larger doses. So all of those blue ones combined would equal 3 small green boxes. So we start looking at the doses there. And then the big green box at the bottom is the maximum yearly dose permitted for an individual staff member. Okay, so that's where we're talking. And then if you put all the green boxes together, then you get those 8 brown boxes. Okay, so all those combined, and by the time you actually get to the brown boxes that are pointed to with the red arrow, that's where you can actually get radiation poisoning. So you can actually have an acute radiation reaction, and then the blue arrow is pointing to the next step, where you're looking at patients sometimes survive if they have therapy, but sometimes they die. And then the box on the far left is with the brown boxes on the left is the actual kind of dose that you would get, that even with treatment you would actually die at some point. So this just sort of tries to put everything into context of where radiation dose and radiation safety is. And if you actually have a look down at the blue boxes, is that living within 50 miles of a nuclear power plant for 1 year is only about twice as high as, well, not even that, 1.5 times as high as sleeping next to someone for a whole year, and is less than eating a banana. Okay, so if you eat 1 banana, then your radiation dose is actually going to be higher than living within the proximity of a nuclear power plant for 1 year. That's a nuclear power plant. And nuclear power plant, I could tell you that coal-fired power plants release more radiation in the atmosphere than nuclear power plants. And so if we're talking about a highly engineered waste management facility that really releases absolutely zero into the atmosphere, you're literally camping on the fence line for a year and getting less than eating one banana. So it is very small and negligible. You couldn't actually physically measure it compared to actual background radiation. So, part of this is sort of scaremongering, and this is my concern. When you hear talk from the anti-vaccination groups that argue that they didn't need vaccinations for the Black Plague, they're right. They didn't have vaccinations in the Black Plague, but 450 million people died. 60% of some national populations were wiped out because they didn't have vaccination. So when Friends of the Earth claim that nuclear medicine kills more people than it saves, let's look at the numbers. Since ANSTO, emerged, and nuclear medicine emerged in Australia, and we're approaching the 50th anniversary of our professional body in 2019, more than 50 million procedures have been done in Australia. So more than 50 million procedures have been done in nuclear medicine in Australia. It's not just about lives saved, it's about lives changed, the improved quality of life, and how that returns to the economy. So, to suggest that nuclear medicine kills more than it saves is a little bit akin to anti-vaxxers claiming that you don't need vaccinations because they didn't have them in the Black Plague. So let's wind that into a bit of a summary. Opal costs about $400 million as a centralized national facility. For the cyclotron network that you would need to meet their requirements would cost more than the price of 4 Opal reactors and still not provide equitable service and still not provide the same quality of product that we currently get. And we wouldn't have the manpower to service it. So in reality, the network that the MAPW and ACF push forward would never be able to be constructed, and as a result, would end up with this really poor quality nuclear medicine service that would fall well short of what's currently provided by ANSTO. It also increased the cost per unit of activity of technetium. Okay, so our overall cost would not just increase a little bit, it would increase enormously with both cyclotron production or the importing model. So both of those, you would see a significant increase. That would actually produce a significant tax burden, and as a result of that, would also leave some communities where nuclear medicine services would be unaffordable. So when you sit there and say, what's the cost? What's the real cost to the health and well-being of Australians and the health and well-being of every Australian? It would be an enormous burden. It would be an enormous cost to be going down the line that the MAPW and ACF are pushing forward. So Opal's cheap and efficient, offering flexible service delivery and world-leading capability. When the rest of the world envies what we've got, it's kind of a little bit embarrassing that we've got actually lobby groups within Australia saying, "Oh, let's close it down and rely on importing or other means." We are the envy of the world. When we're the envy of the world, it means we're doing something right. We've actually got a model that works, and everyone else wants to replicate it. Cyclotrons can produce technetium directly, and we know that. We've known that since 1970. But the costs are significantly higher, reliability is lower, quality is lower, and the service would be lower. We'd end up with a 3-tiered healthcare system. We can't build our healthcare around unicorns and rainbows or magical thinking. It's crazy. We need to build it on facts and information and science. We can't sit there and go, okay, here's our healthcare system, here's our unicorns and rainbows. Let's think about things magically and hopefully, cross our fingers, things will work out. So let's be very, very clear. The MAPW and the ACF are proposing increasing global waste. This is their proposal. So when they actually talk about, cyclotrons and importing, what that proposal means is increasing the global waste footprint, increasing the radioactive global waste footprint. They're talking about increasing uranium enrichment. Both those things seem completely counter to their philosophy for the parent body of ACF and MAPW. They're talking about increasing the costs of products. They're talking about decreasing the reliability of those same products. They're talking about putting more radiation on the roads, more radiation in the planes, increasing the transport routes. decrease in the quality of the products. Okay, creating an infrastructure that will cost billions of dollars that can't be manned. We don't have the manpower to do it, and provide a service that's inequitable across rural and regional Australia. Okay, if we're happy for our rural and regional communities to have a way lower healthcare provision, health outcomes, then that's what they're arguing. But they're arguing this because it's okay. The waste is left overseas. It doesn't matter that there's an increased radioactive global waste footprint because it's someone else's problem. Okay, so it contradicts their own policy, and it really is not environmentally friendly, nor does it show any degree of global citizenship. And here's the problem, and the reason that I've done this presentation is because we get so much coming in. It's called Brandolini's Law, and it basically means the amount of energy that you need to refute the rubbish that's been put out there is many orders of magnitude greater than it is to produce it. So it's really easy for the MAPW, the ACF, or Friends of the Earth to throw these kinds of bombs out there and go, okay, this is fact. Right? And it's not fact. They've just made this stuff up. There's no scientific merit to these arguments. And the amount of energy and time required by people like me and my colleagues to then refute that, provide evidence that that's not true, is disproportionately many orders of magnitude higher. And that's what they count on. They count on being able to throw bombs out there, having people get sucked in and believing it, and then us not being able to change the scientific perspective on it to get the facts out there. And it's enormously disrespectful. If you think about it, is it the one thing that for me that hurts me the most is when people are dishonest. And Australians are clever people. Australians like to have the answers. They like to ask the questions. And when groups selectively pick little bits of information and then cage them in a nice image that suits their political agenda, and then puts it out there as if it's facts, it's showing enormous disrespect to the communities that they're actually putting this information into. Is it when you lie to a community to get what you want politically? Yeah, that's the greatest form of disrespect that you can actually have. And we argue that with politicians. We can't stand it when a politician lies to us to get a vote. And yet we seem to turn a blind eye to our other lobby groups, whether they're environmental groups or other groups that do the same thing, where they lie to us as a community, pull the wool over our eyes to actually exercise their political agenda. And so it's a little bit like this quote or this diagram, and I guess that when you sit there and you get a little kid who's sitting in bed and they're scared about the monster that's under the bed. What do? Is it when you're worried about that monster under the bed, do you pull the covers up over your head and wait for the sun to come up in the morning and hope that you weren't eaten by the monster during the night? And when you do that, and that's a common reaction, but when you do that, what you're actually doing is you're actually giving power to the monster. What you're actually doing is feeding the fear. You're actually feeding the monster and making the monster much bigger than it actually is in reality. Whereas if you actually just leaned over the bed and you had a look under the bed, then you might realize there's no monster under there at all. That there's no actual substance to the monster. The monster has no volume. There's nothing to be scared of. Okay, or you might actually see a little rat sitting under your bed that's actually eating the crumbs that have been left in your lunchbox. Okay, picking up the scraps, and then you realize it's not a monster. It's just a dirty rat. And when it's a dirty rat, what happens is that you can either ignore it, so you go back to bed, or you can actually get an exterminator in. Because if you don't get an exterminator in, then what happens is the rat breeds and you end up with a plague of rats. And when you have a plague of rats, that brings disease. And we know that. Okay, so my advice is that don't hide under the covers, while we're actually sort of being bullied. And this is what happens in these communities. We're being bullied. These communities are being bullied into the darkness. Right? You're being pushed into the darkness. And it's not. Okay? You need to be looking for the light. You can't wait for the light on this. We can't wait for the light on this, because by the time we wait for the light on it, it's all over. There's no sense waiting for the light. Okay, you can go looking for the light, and I think that's important. Go searching for the light, and I'm hoping that this presentation is part of that allows us to shed some light on the truth. And then you can share the light. Okay, so share the information that you've learned. And then, of course, the most important thing is collectively as a community, we need to shine. We need to be the light, not just go looking for it. And so when you're actually having those debates, you know, think about all the information. Don't just take my word for it. Think about who the experts are. What are the drivers when you're talking about this debate? What are the drivers? Do they have skills in it? Do they have experience in it? What are their values? And are they values driven? And so if they're expert, they have all those things. They're not driven by a political agenda. They're actually coming together and giving you that information. So I hope that was useful. More than happy to answer any questions. You flick it via email, and hopefully that provided some enlightenment.